Okay, I think we can get started. Welcome, everyone, to our second webinar in our series. First slide, please. We can't answer very specific medical questions, and if you do have a question, just go to the Q&A icon at the bottom of your screen and type it in. We're also streaming to Facebook Live, so if you're on Facebook, you can type in your comments. And we're recording, and we'll post the recording to uspainfoundation.org/webinars. Next slide with a few disclaimers. Great. And then we can go to our next slide. And we want to thank our corporate counsel for sponsoring our pain awareness campaign. And now we can go to the first actual slide. Okay, great. So in preparation for Pain Awareness Month, we had conducted a survey of over 2,000 people living with pain. And one of the key findings we've chosen to focus on for this webinar is the relationship between doctors and patients. I would argue that that relationship is particularly important with an illness like chronic pain because it is so devastating, so lonely, and its treatment strategies are often uncertain. At best, people with pain feel their healthcare providers aren't equipped to manage their pain effectively. And at worst, people with pain feel unsupported and stigmatized. Next slide, please. The detailed responses behind that statement are that 63% felt stigmatized by their providers, and 69% didn't or only rarely or sometimes feel that their provider was on a team with them. 53% of our respondents answered no or only sometimes when asked if the providers helped them understand their options for managing pain. And nearly a quarter rarely or never felt validated or listened to. And although only 72 caregivers took our survey, it's noteworthy that 71% of caregivers felt that providers were the top barrier to care. Next slide, please. So why do patients feel this way? Doctors lack knowledge of current best practice in pain management. Patients often think their doctors, don't get enough education in managing pain. And when asked in our survey to name their top policy issue, patients most frequently chose increased pain education for providers. Research certainly confirms this. In a 2018 systematic review of pain medicine curricula internationally, 96% of medical schools in the US had no compulsory dedicated teaching in pain medicine. And the median number of hours of pain content in the curricula was 11 hours, which is the lowest of any industrialized nation. Next slide, please. Patients can't find doctors willing to treat them, particularly in the past 5 years. A 2019 study of Michigan primary care practices found that 43% would not accept patients who are on opioids. And many chronic pain patients have been dismissed from practices because they use opioid medications to manage their pain. Many others cannot even find doctors who will treat them even if they don't use opioids. Next slide, please. Pain, of course, is invisible and lacks objective measures. And that invisible nature of pain often means that patients really don't appear as disabled as they might be to the physicians in a short time that they see them. The lack of objective biomarkers means that the presence and severity of pain can't be easily proven. And patients frequently report being doubted or dismissed, disbelieved, or accused of being malingerers. Next slide, please. Now, why do doctors feel this way? Well, certainly time constraints don't allow for the complexity of caring for people living with pain. Less than 1%, actually 0.6% of physicians in the US are board certified in pain medicine. And there are 50 million Americans living with pain and 20 million with high impact chronic pain. Most people then have to be seen by primary care providers. And the average time the PCPs spend in visits in the US is 18 minutes. That certainly doesn't allow for the lengthy history and risk assessment, a thorough pain assessment, and a discussion of many different options for managing pain. to develop a treatment plan and then work to revise the plan so that it's really working for patients. It makes sense that such a limited amount of time is going to put strain on both doctors and patients. Next slide, please. And then there is the fear of regulatory scrutiny. The DEA and state licensing boards have really stepped up investigations of opioid prescribing, and the CDC guideline and its codification into law in as many as 38 states have set, in some cases, very strict limits on daily dosages of medication. Even hospital and medical practices, have now severely restricted or prohibit opioid prescribing. And there's very serious consequences that threaten physician livelihoods. Next slide, please. And then there are insurance barriers that can be very frustrating. Often other options that doctors might want to offer patients in pain aren't covered or they're inadequately covered. And given that high impact chronic pain patients often cannot work, they can't afford to pay out of pocket for some of these treatments. And then the practice has administrative hurdles with insurance coverage because there's many therapeutic options that have to be approved by insurance companies, and it really burdens physician staff to wait for that approval. Next slide, please. So these are just a handful of the many factors that are straining the patient-provider relationship. And part one of our webinar on Tuesday looked in depth at the patient side, including the overwhelming burden of living with debilitating chronic pain. We are next going to hear from Dr. David Nagel about the burden on physicians and what can be done to improve this relationship. And then we're going to hear about some possible policy solutions from Drs. Fishman and Lawrence. Next slide, please. But before we do, I want to set the context for large-scale improvements in pain care. These only come about through a great deal of advocacy on the part of stakeholders. And that advocacy has translated into provisions in some key federal legislation that have led to advances in pain care. So the Affordable Care Act, which was passed in 2010, mandated the landmark Institute of Medicine report on pain in 2011. And among its recommendations was the competency-based medical education that Dr. Fishman is going to describe to us today. And another IOM recommendation was the need for a national pain strategy, which was developed in 2016. And among many other recommendations was interprofessional competency-based education that Dr. Fishman and his colleagues undertook with funding from Mayday, SAMHSA, and the California Healthcare Foundation. In 2016, the Comprehensive Addiction and Recovery Act mandated the Pain Management Best Practices Task Force report, which was completed in 2019. And its seminal recommendation is that best practice in pain care is the creation of individualized, multimodal, coordinated treatment plans. It was followed by the Support Act in 2018 that had a number of pain provisions and specifically called on CMS to confer with the task force and use the task force recommendations in creating an action plan on pain. The work that Dr. Lawrence is going to discuss that CMS is now undertaking to create unique, comprehensive codes on pain management grew out of the task force recommendations. Next slide, please. So I am delighted to introduce Dr. David Nagle. Dr. Nagle is a physiatrist who specializes in pain management and has been in practice for 30 years in Concord, New Hampshire. He is author of the really great book, Needless Suffering, How Society Fails Those with Chronic Pain. He is the chair of the Pain Management Best Practices Committee for the NFL Players Association. Dr. Nagle founded the New Hampshire Pain Collaborative and is a member of the New Hampshire Governor's Opioid Prescribing Council. His special interests include the doctor-patient communication and advocacy and social policy and justice for those who suffer from chronic pain. So please welcome Dr. David Nagle.
Oops. Hear me?
Yes.
Yay. All right. Hi. Good morning or good afternoon to whomever I'm talking to right now. It's really an honor for me to be here to talk to you about something that's really important to me. I've been involved in advocacy work for chronic pain and other things for over 30 years. And I first today learned the lesson or learned the term why child from one of my patients this morning. I've always been a why child. I have always wanted to know why things were they are. My practice of civil disobedience began in 3rd grade, and my butt's never recovered from that, but I've never stopped trying to ask why we do things the way we do them. And then if I don't like the way things are, I think there's a problem trying to go about changing them. So the only message that I really want you to take home from this entire presentation is that if you don't speak up, your voice will never be heard. And I've learned in policy development and other things like that, just how often it is important to have a voice and be a stakeholder and so on and so forth. So the other thing I want to show, this slide is Nick Willenda crossing over in front of Niagara Falls on a high wire. I was on the other side of that, about 50 feet away from where he finished his walk. And if he can do it, so can we. Next slide. The only reason I'm including this slide, besides Jim Plunkett, who's a Hall of Fame, or not Hall of Fame, he's an NFL football player, 2-time Super Bowl champion, suffers with severe chronic pain, and that's his description of it. But I think our focus today is primarily on chronic pain, not the myriads of other types of pain. So that'll be our focus. Next slide. So a couple of years ago, some folks at the New Hampshire Hospice and Palliative Care Organization asked me to give a talk on why are we afraid of people in pain, what the barriers are to providing decent pain care, both in palliative and hospice care, and more importantly, like what we as a community can do to change that. So I went about doing that. The way I started was to look at these barriers, which were defined in 1994. And this is pertinent to cancer pain, but it can be generalized to anything really. And over the years, people quoted this or cited this resource innumerable times. This was based on comments from as early back as 1983. And what's important about this slide isn't what's necessarily on it. I think you can all just look at the barriers and see what I'm talking about. But what's important about it is that I started pain management in 1987, and opioids back then were a major no-no, much like they are now. I mean, people were recovering from a previous opioid crisis, and they were really frowned upon when we used it. So in a way, things are the same, but in a way they're different. Next slide. The way this was divided in was patient factors, doctor factors, healthcare system factors. So next slide. What I decided I wanted to do was, well, let's look at what's going on now in 2022 as opposed to then. And I should say 2020, this was done 2 years ago. And interestingly, it was done before COVID. So there are probably some new factors in here as well. And expand the look at this to see what barriers we're facing, what's the same, what's different. Some of them, I just added things like, we have an opioid crisis now. And there's a lot of blaming going on as to who is responsible for that. And unfortunately, when you usually blame the wrong person, or you don't look at things in a big picture. And that's kind of what's happened. Next slide. There's 2 areas that I really want us to focus on going through the rest of this talk. One is the problems related to medical practice, because the practice of medicine has changed dramatically from 30 years ago. 30 years ago, 74% of doctors or more were in private practice, meaning they had a decent amount of control over what they did, how much time they spent with the patient, so on and so forth. As the medical industrial complex, or whatever you want to call it, has invaded the practice of medicine, and the technological aspects have invaded the practice of medicine, things have changed dramatically from, a practice where I cared about you to, I'm not sure what I care about anymore. The thing, terms like product line have invaded, productivity criteria, all sorts of weird things that in business are normal, but in a professional relationship are not, have invaded. and this whole concept of corporatization where time is money is invaded. And we have all sorts of other things that we're buffing, like the electronic record, where doctors are looking at their computers more than they're looking at patients as the cost of practice has gone up. You know, you have to see more patients per unit time, and that's what Cindy was talking about earlier. A primary care visit in our community used to be an hour for a new patient. Now it's like she said, it's about 20 minutes, and that's dictated by a corporate entity. It's not dictated by the doctor. They have no choice, and if they don't succumb to that, then they can find themselves without a job. People became less comfortable with a broad, you know, when I started out, I actually started out with the Indian Health Service in Alaska, and I did everything. Now everybody's become so specialized, and the communication, despite the electronic record and despite email and despite all that other stuff, people talk less and less, and that creates more fragmentation. There's a lot more peer pressure because there's doctors that, you know, there might be 50 doctors in a practice, whereas before, you know, when I started out, there were like 8 or 10 of us in the practice. We all knew each other. We were best friends. Now I don't know any of my partners. There's a lot of pressure on me to conform to some mean, and the problem in pain management is there's no consensus in the group at all on how we're supposed to manage that. So the alpha males tend to dictate to the others what we can and we can't do. Next slide. And then these are just a couple more getting back to the patient issues. Social support is absolutely critical, and this is a pet peeve or a big issue for me, is the whole decline of the family in our society, at least among some ethnic groups, and it's absolutely concerning, but that's a whole nother topic, and that's why I included that. Next slide. And I'm just going through these because a lot of these are not totally what I'm interested in talking about, but the other one is government policy, and Cindy also pretty much hit on that. You know, the governments and the insurance companies, to be honest, have become increasingly involved in telling us how we can and cannot practice healthcare. And I don't personally think it's a good thing, but I do understand where this is coming from, which is another long story. The big factor that we're looking at is the CDC release in 2016. You know, superficially, the CDC policies were not dramatically different from the Federation of State Medical Board guides, which came out as early as 1997. You know, they have some value. The concept of at least pseudo evidence base has some value. But the problem with it is they never really anticipated the ripple effects of it. And that's had a lot of adverse effects on how we provide care to patients, especially when opioids are involved, the whole concept of the development of opioid refugees. Unfortunately, we have this really weird suicide watch in our state that I'm really embarrassed about, but we're trying to collect data on who's dying because they're of non-consensual dose reductions and things like that. And it's kind of scary, and it's all a ripple effect of, I think, what was intended to be a good thing, but turned out to not be so good. Next. And I'm really interested in special populations, which is why I included this. I had a guy from the VA yesterday, and I'm just really concerned about the level of his pain care. And women in pain is a big issue. Women and other things is a big issue. And disparities are huge issues that we need to address. Next slide. So for the last 30 years, I've been very interested in the development of community-based, comprehensive, integrative pain management programs. People are using all sorts of fancy terms like patient-centered care, blah, 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 blah. You know, I trained at the University of Rochester under the biopsychosocial model of medicine, which has been there since the 1940s. These are not new models. They've been around forever. But that was what I wanted to do. When you deal with complex disabilities, that's what you do. You work integratively, you work with other people in a group, you communicate, and you develop a plan that includes the patient. Unfortunately, because of everything that Cindy outlined in the beginning, that's not happening. And what also bothers me is the elephants in the room of opioids, opioid policy and dollars. Remain part of the discussion that I think interfere with our ability and create a barrier between doctors and patients, and a real fear. Next slide. So I just want to give you 2 examples of why I'm afraid, and why my colleagues are afraid. about, I don't know, 4 or 5 years ago, I was at a New Hampshire Legislative Committee meeting, or Medical Legislative Committee meeting, and we were just sitting there, and all of a sudden some guy comes walking in and goes, "Did you hear what happened to blah, blah, blah?" And I says, "Well, nobody heard what happened to blah, blah, blah. So what happened to blah, blah, blah?" So this gentleman was a family practitioner. He lived up in the northern part of our state, New Hampshire, which is very rural. There's not a lot of resources up there, and he was one of these God only loves him for being up there, because he was providing medication assisted therapy and pain opioid therapy for people in pain over a broad area. As a reward, he got named as the largest opioid prescriber among primary care doctors in the state. And so what happened to blah, blah, blah was, on that day, the DEA, for whatever reason, which they've never explained, decided that his practice should be raided. So they raided his practice, subpoenaed all of his records, and for the next 4 years terrorized him, ruined the lives of innumerable patients. I eventually got involved with this because I was actually asked to serve as an expert witness for him against the DEA, which was pretty frightening by itself. Fortunately, that never had to happen, and I'm not totally sure why. I personally think they never thought that somebody would be willing to serve as an expert for him, but in the end, they never charged him with anything. And so the problem with that was that, all right, all you have to do to create fear of prescribing opioids to a patient in pain is to just put one head on one pole and make it very public. And that's what they did. And in the ripple effect of this throughout our community, even among the pain groups, was we don't want to get involved in this anymore. And we started seeing this increasing wave of non-consensual dose reductions, a lot because of that. And so at some point that started to die down, and more recently we had an invasion again of the federal government for reasons I don't understand at all. It's called the Northern New England Prescription Opioid, too much letters in this acronym, opioid strike force. And their whole reason to exist was to take care of those bad doctors. And they had a very big public press conference to present this. Never informed anybody at the state level. We, with the governor's advisory committee, were never informed this was going to happen. And it's just, it instills fear in you. Why would you want to put your life, your practice, everything at stake to take care of somebody in pain? And that is a huge ethical dilemma. Next slide. As I said earlier, right now, I'm very fortunate. I'm in private practice. I have a lot of control over what I do. I still spend an hour with a new patient, but my colleagues don't have that luxury. 20 minutes is a lot of time now, and a lot of practices are dictating that you can only see one problem per visit. So where does that leave somebody with a complex disability such as chronic pain? If you want your job, all of a sudden now the patient becomes somebody to be feared because they're not going to fit into that neat little preconceived or notion or that box that the corporate healthcare people have. Next slide. But things are worse than that. And this is a story that appeared in Pain News Network. I became involved in this because out of the blue, the estate of this gentleman called me up and asked me if I would be an expert witness for a lawsuit against his doctor. So, they then sent me 2,500 pages of medical records. And what I found out was that Doug Hale was a gentleman that had chronic pain, multiple sources, not just a single source. He had been on methadone for over 20 years. His dose varied, but it wasn't like something that raised a lot of red flags and things like that. And there was some subtle ones, but nothing major. His primary care doctor was wonderful. He was always there for him, always took care of him. And my observation from a distance is that his private practice gradually became corporate. In addition, one of the academic institutions nearby was heavily involved in his, subspecialty care. And they basically said in their notes, and have become very anti-opioid in their practice there, is that they basically said that he really needed to come off of his opioids. And And then that message trickled down to the doctors in the practice and who had to cover for this guy. And they basically, you could just read this in the records. They've started putting a lot of pressure on him that this guy needs to be off of pain medicine. So then the strategy was to send him to an addiction center to be detoxed. So after 20 years of methadone, he was detoxed in 6 days. About a month later, he was dead. This was part of his suicide note there. And the reason why I'm telling this story is that it's the peer pressure issue, the corporate pressure issue, the failure to agree on a set of defining principles basically led to the death of an individual that probably was totally I always say probably because you never know, but it was probably totally avoidable. The man had not been suicidal prior to that. And that was it just basically tells you another fear that we have of patients. And anyways, next slide. So this is basically, by the way, how are we doing on time, Nicole? 128. What do I have? Does anybody know? Oh, I got time. Anyway, so this is my big concern about pain management. Rule of thumb is follow the money. If all you pay for are pills and procedures, that's all you get. I think we have an epidemic of interventional pain procedures that have never ever proved their cost benefit justification. Now we're going to other pills that, you know, it's not clear that they really work very well. And that really bothers me. And what I've always been interested as a physiatrist and as a U of R grad, because the biopsychosocial medicine model is important there, is how do we empower patients by giving them the ability to manage their pain with the tools they need, and how do we give them access to all the services they need in a world that's just not allowing us to do that. We have a new stigmatization of pain patients as somebody who may potentially be on opioid. So the minute you come in the door, tell somebody you have chronic pain, all of a sudden you're immediately stigmatized as a potential opioid patient, and too many patients are thrown out the door. So how do we, you know, those are the barriers. How do we get past that? Next slide. And this whole model, the patient's screwed. I really hate that picture because it looks so painful. But anyways, and I do interventional pain, some of it. This is not what I would do to a patient, I ever hope. Anyways, next slide. What we want to do again is empower patients. We want to give them the ability, by working together as a team, to try to understand that each one of us by ourselves does not have all the answers to help the individual, but to help them and their family find a better life despite the problems that they deal with. And we want everybody as a stakeholder to be included in that journey. And that includes the government, it includes the insurance companies, the pharmacies, the workplace, etc. We should all be part of that journey. Next. So what we did in New Hampshire was, I've been involved in a lot of legislative and advocacy work over the years, and a lot of medical society work and a lot of medical organization work. And the one group that always seems to be absent are the patients. And, you know, they're the only ones that are important. We're all there for them, but they're not included. And I remember years ago doing something with Myra Christopher, and that's actually how I met Cindy. Was she always insisted that a patient be part of any presentation to give their side of the story. So in our state policy development, there were never any patients involved. And I said, this has got to stop. And we really, a lot of my cries fell on deaf ears. So what I decided to do was to help with 3 other people, one of whom I hope is on this call today, start a thing called the New Hampshire Pain Collaborative, which was supposed to be a patient-run, patient-directed organization with a goal of educating the community, legislators, policymakers, patients, families, on the problems that chronic pain poses and potential solutions. We have several different members. Bobby Blades, who may be on this call, who Cindy knows very well, started a support group, which she's done a fabulous job of bringing patients together to help support each other, and then through that to create a support network which is broader in the state. One of our members does a lot of one-on-one advocacy, meaning he goes into a doctor's office with a patient to help them advocate for themselves. Um, but the other thing we got involved was with this legislation. And I think a lot of you, I can't go into detail about the CDC guidelines, but the one very controversial guideline that frankly led to a lot of bad public policy was the decision to include a specific morphine milligram equivalent as a guide. And they came up with a number of 90, and 50 and 90 are in the guide in two different places. And they're in the current guide as well, which I've also complained about. But I don't personally think the numbers by themselves are a problem. It's how people have chose to interpret them as the problem. And in New Hampshire, we saw a wave, as I said earlier, of non-consensual dose reduction because of that. And a lot of patients were harmed. So we decided that we needed to pass a law that would get rid of that from state law. And after 3 years of work, by bringing together a lot of stakeholders, including doctors, the medical society, some insurers, pharmacists, multiple legislators, we created a bipartisan bill. And this was functionally the conclusion of it. And this is New Hampshire state law right now is, I'm just going to summarize it, but the treating practitioners can administer care based on objective evidence without fear of reprimand or discipline, that there cannot be any mention in any state law of milligram morphine equivalent, and that if patients are following the rules, they should not have their medication regimen reduced, and that we ensure that patients are treated with dignity and not denied medications needed to treat their conditions. A lot of that language, frankly, is superfluous, but we felt that we didn't want to leave any wiggle room in how these things were interpreted, so that's why it was in there. The other law that we passed, which I was really proud of, was, CMS is going to, I think they already do require that all opioid prescriptions be done e-script, by e-prescription. The reason why that's important for me has nothing to do with avoiding, diversion and, whatever. The big thing for me was increasing access to care. I have patients that live 200 miles away from me. For them to make a trip for me for an opioid prescription is a journey, and especially with gas prices being what they are. By going to e-prescription, I can do a telemedicine call with them and I can e-prescribe for them, which dramatically improves the quality of care and access to care. And so that was our reason, and we had to argue with the people in the state as to why this was important. But we did get it done, and that was really fun too. The other law that we're working on right now is we feel that it's important to increase access to all therapies in some way, shape, or form, and we have a lot of bipartisan support on that. We're certainly building, hopefully, on what Cindy accomplished in Massachusetts, but these things are all really important to us, and that's what we're working for, to try to change this fear dynamic or whatever. You can pass a law, but then you got to make it real. So that's our next step, is to try to make this real. And that's where we're at right now, is promoting what we've accomplished, trying to give doctors, lessen their fears. And again, we really need to get to multidisciplinary care, not focusing purely on a drug or an injection or whatever. Next slide. And this is my last one. My big interest for the last 40 years has been doctor-patient communication. It was the main reason I went into healthcare. It's the main reason and the only reason I went to the University of Rochester, because it's still the only med school in the United States that teaches it as part of the 4-year curriculum. I started a professorship there in biopsychosocial teaching of pain management, solely that we could increase that model to treating pain. I'm in the process of 2 books. One is for doctors, one is for patients. And the second book's called The Art of Keeping Your Doctor Human. And there's a number of recommendations for patients, but I wanted to leave you with these, as how you can at least empower yourself when you go see your doctor, understand the fears and the limits he's under, or she's under, and do what you can to make the most out of that interaction. So the first one is, like, prepare for your visit, like you're preparing for a Broadway play or something. Have a script, decide what you want to say, understand your doctor's only got 20 minutes with you. How do you make the most of those 20 minutes? And if your doctor only spends 3 minutes with you, I mean, I hate to say it, but go find another doctor. I know it's easier said than done, but for the amount of money that we are paying to see a doctor right now, and I'm saying we, because I'm a patient too, I'm insulted if a doctor walks in and out of my room in 3 minutes. That is just not acceptable. And you need to be willing to tell them that, you are the boss, you are paying the bill. Second, bring an advocate. And sometimes the advocate's a tape recorder or something, but I swear, I tell you, it changes the entire relationship when there's another person there. And I don't know why it is. It feels like, there's somebody overseeing my behavior, and I'm much more cautious and careful, and I don't know why, but I am. But I think you get a lot more out of the relationship. Plus, you've got 2 ears to hear everything that's said, so that when you leave there, compliance is important. But if you don't remember what to comply with, then that's a problem. So you should take notes, have an advocate, have them here, make a tape recording, all those things. And then finally, another way that you can empower yourself is you need to get copies of your medical records. It is amazing what ends up in a medical record, and the electronic medical record, as far as I'm concerned, is a qualified disaster. Basically, anything that ever happens to you and a doctor will go in there and stay in there forever. And it's important that you know what's in there to correct what's wrong, because sometimes, it's amazing how often patients are accused of being a drug addict when they're not, just because one doctor's point of view is that you are. All of a sudden, you are now tainted for life because of that. You also need to know that healthcare providers do not keep these records forever. 7 years is the norm, or is there's no legal requirement, but most people keep them for 7. We keep them for 10. After that, it's gone. So, if you have your records, it's really helpful, especially for complex chronic disabilities, to have a running tab. And then find a good way to summarize that. I have patients that bring in a summary of all their care on one piece of paper. It is the best thing ever, because I know at least that element of them right away, so I can focus on more of our relationship and what I can do to help them, and not spend so much of our time just dredging up information that, whatever. And I like to get it from the patient. I really think it has a lot of value to hear it from the patient, not the, doctors here think they're filters, they hear what they want to hear too often. And a lot of times what they say is not exactly correct. So to hear it from you is really important. And next slide, and I think that's it. And that's me. So
Dr. Thank you so much for that really excellent talk. First of all, for really explaining to us the position that physicians are in, which often I think patients don't really understand the full picture, and for your legislative work. So pushing back on some of those laws that have been created is a huge achievement, and I know it was a lot of work. And for your advice to patients, we're getting a lot of comments already through, and thank you for writing the comments into our audience, thanking you for the work that you're doing. So, and wishing you could be their doctor. So thanks very much for that really terrific talk. And next, I want to introduce Dr. Scott Fishman. If you can put up the next slide. Dr. Fishman has done really seminal work in pain education and pain medicine and interprofessional education for nearly the past decade. And he's going to tell us about some of that really excellent work. Dr. Fishman is the Fullerton Endowed Chair in Pain Medicine, a professor of anesthesiology and executive vice president of the Department of Anesthesiology at the University of California, Davis. He is the founding chief of the UC Davis Division of Pain Medicine, a position he's held for 20 years. He is past president of the American Academy of Pain Medicine, past chairman of the board of the American Pain Foundation. He is the author of The War on Pain, Listening to Pain and Responsible Opioid Prescribing. He has won numerous awards, including the American Pain Society John and Emma Bonica Award for Public Service, and the American Academy of Pain Medicine Award for Outstanding Contributions to the Social and Political Aspect of Pain Medicine. So I am really pleased and delighted that he could be with us. Dr. Fishman, welcome and thank you.
Thank you, Cindy, and I hope you can hear me okay.
Yes, we can.
And I want to thank the U.S. Pain Foundation for their work and really for this very profound survey that I think should go way, way beyond all aspects of the pain field into major healthcare concerns because of the findings. Also want to thank Dr. Nathan for that really profound and I would say courageous presentation. I've got to say that he said many things that I would love to say myself, and I think we could focus hours of discussion on the things that he put on the table. But my talk today is about my work that I've done in addressing the education gap. And unfortunately, the slide here is a little bit shifted because we sent it out by email. So we can go to the next slide. And there we go. And really talk about the problem that I think is the elephant in the room. My dear friend Ben Rich, who was a bioethicist that Cindy knew and some of you may know, passed away a few years ago. He'd say that it shouldn't take an act of courage to treat pain. And in many ways, that's the foundational problem that Dr. Nathan was speaking about. I would argue that a lot of that comes from a lack of knowledge. And this lack of knowledge has been well described in terms of the discrepancy between the need and the lack. And I would argue that a lot of it occurs, there's not a conspiracy. A lot of it is in the problem that pain is part of every clinical area of medicine. And yet it's not the primary part of any. So when we go to teach pain, there's no real single forceful advocate, and it has to be separated out and it gets lost at the curriculum table. Next slide. This has been identified by really every major group that's looked at the problem of pain in America, including the National Academy of Medicine, which was called the Institute of Medicine back in 2011, when they, basically said that that pain is insufficient, pain education is insufficient at really all levels for all health professionals. Next slide. The National Pain Strategy that Cindy and I were both involved with said that although pain is one of the most common reasons for healthcare visits, most health professions education programs have yet to give it adequate attention. Cindy addressed some of the later work that has confirmed this. Next slide. And really, in my opinion, I can go on and on about the depth of the knowledge of this, but I think everybody agrees on this. And the problems here is that we really don't have a system for the schools to demonstrate that they're producing the kinds of graduates that people need, which is, you would think that the schools of health for doctors, nurses, pharmacists, psychologists, physical therapists, you name it, alternative therapists, would at least train people to do the things that they're going to treat most commonly. And there's nothing more common than pain. And yet they don't. And I would say the reason for that and the lesion here, the place where we can treat this is with certification and accreditation. If we can get our accreditors to step forward and say, you know what, we want these schools to show us that they're actually training people to be competent to treat pain, I think that change would happen overnight. The other issue is that I'm guilty, as is my whole field, of trying to create that perfect curriculum for decades. And I realized about 10 years ago that you've seen one curriculum, and that we were really putting the accent on the wrong syllable. We were trying to create that curriculum that everyone would endorse. And it turns out every school does it differently. Next slide, please. And the issue around this is that every school is going to take a different path. But if we could come up with a consensus on where that education should end, we might be able to find agreement. And that this education gap is actually something that can be understood. Next slide, please. And that's where we came up with this idea that if you don't know where you're going, you may not get there. You're unlikely to get there. And that trying to create the curriculum was the wrong path because we could never get consensus on that. But when we tried to get consensus on the issue of what should the outcome be of health education, we almost came to immediate agreement that was really quite profound. Next slide. So we pursued, as Cindy said, coming up with core competencies. And core competencies are essentially the outcomes that you wish to have once education has taken place. And we seeded an international group. Sorry, the slides reformatted a little bit. No, this happens with emailing them, unfortunately. So you may not see all the references here, but we'll make sure that these are available as a PDF perhaps afterwards. So the bottom line is that we seeded an international consensus conference, and we spent days going over what are the outcomes that would apply to all professions. And next slide. And this is actually what we came up with, which is essentially the outcomes of every health education school should be, at least in part and large part, to meet the needs of the people in pain. And we came up with 4 very, I think, common sense, rational areas of focus that every health professional should understand what pain is. Every health professional should understand how to recognize pain and assess it. Every health professional should understand how pain is relieved within, again, all of this within the context of their profession. A physician may need to understand it in different ways than a physical therapist or a pharmacist or a nurse practitioner or a PA, et cetera. But within those professional domains, these apply. And then most critically and more nuanced is that each of these professionals should understand how context affects pain, because even though our toolkit may be the same, it's used differently for someone with acute pain versus someone with chronic pain, or a child versus an adult, or a person with a back injury versus someone at the end of life. Next slide, please. So these were endorsed widely, and we created these about, I think about eight to 10 years ago. Next slide. And since then, my university, the University of California, came forward and actually took them and we expanded them within our system, and we published a new set of competencies for not only pain, but also substance use disorder, using the same rubric. What is pain and substance use disorder? How is pain and substance use disorder understood, recognized, assessed? How is it safely and effectively treated, and how does context affect it? The University of California has 6 medical schools, and we have many schools of health professions, and we are known as maybe the largest academic health system in the country. So for us to do this and have every dean of our health professional schools endorse this for curriculum reform was a major step, because the worry that we have, and Dr. Nagel spoke kind of peripherally to this, is that the problem is that we have a great opportunity because of the opioid crisis to re-look at education, but many times that education is simply focused on training people not to use, to be afraid of opioids and not to use them. And frankly, it's appropriate to teach people about safe opioid use and careful opioid use, and to use them only when the benefits outweigh the risks. But if all we do is train people to not use opioids, the driver of why they use them poorly is a lack of education. We're just going to overuse something else like procedures or some other drug group. Next slide, please. So we have a real opportunity here. And actually, we were asked, after we created these competencies by the National Board of Medical Examiners, to review the U.S. medical licensing examination. And for those of you who don't know this, this is the examination that every medical school graduate must take to get a license to practice medicine. So this is probably the most important examination they take. And we again formed a group to go in of world authorities in pain management and education. And under surveillance, I thought they were going to take a tissue sample or scan my retina. They watched us, they gave us the exact test the students took. And we spent 3 days reviewing these. Next slide, please. And looked at every question, as many as we could. And we came up with a rubric of questions we asked about each question to see how much of this test was on pain. And we came in with the hypothesis, because of the data, that pain is not widely part of the medical school curriculum, that there wouldn't be much pain management there. Next slide, please. And what we found was that we were wrong, that there was a large amount of pain management on this test. And then 15% of the test actually directly tested on the subject of pain, but almost 90% of those questions were solely about the one domain of our competencies, which is pain assessment. And you might ask, that's unusual, because the others, it really should be equal, and maybe even weighted to things like, what is pain? But it was mostly about pain assessment. And that was really curious to us. And we thought, this is actually informative. Next slide, please. So what we found actually supported a belief that many of us had, that this concept of pain as the fifth vital sign, which I think was a very, very well-intentioned intervention to address the fact that many doctors would ignore pain, kind of went sideways, and may have caused a collateral problem that this test was reflecting, in that in the year 2000, when the pain became the fifth vital sign, many of you may remember that was the time when you were asked to rate pain on a scale of 0 to 10 at every healthcare experience that you had. That is exactly when we saw the inflection of unintended overdose deaths. And the requirement was that, I think the requirement was that we asked about pain on every clinical visit, but the belief, I think, was that if only we asked about pain and found out the person had pain, we would surely treat it appropriately. We'd surely assess it properly. We would treat it safely and effectively, and we would treat it within the context of the patient's care. But unfortunately, most of the practitioners who were getting these pain scores didn't know what to do with them. And for many, many reasons, in many ways related to what Dr. Nagle presented earlier, they were forced, because of time constraints, resource constraints, lack of education, other influences, to just reach for an opioid, even when that might not be appropriate. So next slide, please. So, with that, we started to address these competencies for pre-licensure education, meaning medical school, nursing school, pharmacy school, to try to change curricula so that it's not just driven by demonizing opioids, but using opioids only when the risks or the benefits outweigh the risks. And actually, they're not, as Dr. Nathan was referring to, if you really take a biopsychosocial view of pain management, opioids are not necessary in the majority of patients who you might see in a primary care practice for pain. And they're certainly not the first choice if you know what those are. Now, the problem that we have is that we're starting to impact curriculum. We need to get our accreditors on board. So if there's something we can do politically, policy-wide, that's really where we should be putting our efforts. But we also, the problem with changing curriculum is it's going to take generations to get those clinicians out into the workforce. And we have a whole workforce out there that will never benefit from curriculum change. So we're now focusing on part 2 as well. So if you can give me the next slide, please. Those are the the folks that are out there in the workforce who never got trained, never will benefit from curriculum. We've got to retrain them as well. So we're working on healthcare workforce reform. Next slide, please. And addressing this, we started by doing something called Project Echo, which is, really a well-known process of really using video connection to clinicians who don't have the access to specialists. I'm sorry about the slides. You may not be able to read some of the words here, but the bottom line is that we started training primary care clinics. Echo was initially, one doctor to another. We expanded it to training the clinic, an interprofessional group so that they could, as a group, improve their pain care. And we did this for many years. And it was so successful that insurance companies were coming to us to help. And we can go to the next slide. Insurance companies were coming to us to offer to pay for these trainings, which they did for a while because they knew that the return on investment was there. It improved patient satisfaction, improved provider satisfaction. There were less visits to ERs. There were less resources in drug costs. Next slide, please. So there were many positive outcomes. And this just gives you a sense. We published some of this previously in the reference that's here. We had essentially less opioid crises and overall improved outcomes with less resource utilization, exactly what insurance companies love. Next slide. The problem was there weren't enough of us to do all of this. And we just, we're also a pain clinic taking care of patients all the time. So we recognized this was a really good thing, but it was not enough. And we needed to change. So next slide. So we thought hard about it and we realized that there aren't enough of us to train. So we actually switched to a train the trainer model, which we published on, as well as the ECHO model in academic medicine as an innovation, where we started to get clinicians, again, from all professions, to work with us for a year by telemedicine, by telementoring, by using video, to train them to be not only improved pain treaters, but to be the trainers for their partners and their communities. Next slide, please. We did this through really standard video conferencing technology that prior to the pandemic was pretty new. And now actually it's become much more commonplace. We were having folks come in and we would meet together at the beginning and the end of the fellowship. And these primary care clinicians would stay in their practice and we'd meet with them, every week or two. We'd have didactics, cases. They would each have a mentor, so they would have real-time connection. And we find that all of this is very, very important in the outcome. Next slide, please. And to date, we've trained over 200 fellows that reach out to probably 2,000 clinicians in terms of them becoming trained, not only as primary care clinicians with added training in pain, but also agents of change for their community. And we're trying now to really expand this as a force magnifier. Next slide, please. The satisfaction here has been overwhelming. Unfortunately, it's very hard to do the research that we need to do to show the effectiveness of this, although it's pretty self-evident. NIH really doesn't pay for research about education, and we've actually proposed a really detailed scientific study of the advantages of this, and unfortunately, it's hard to get policy around education. It doesn't make sense when you really look at it. So again, from a policy perspective, this is where we really can push for change, because the education gap is truly the elephant in the room. Next slide, please. So we envision that this can be really scaled on a national level, and we're working to cover the state of California right now. We've been funded through our state, but we're talking to the CDC and others around really bringing this to a much larger scale, where we could have a trained pain person in every primary care practice to hopefully change the culture of pain care, very much apropos to the model that Dr. Nagle so clearly presented to us. This is my hope. This is the work that we are, amongst all the other research on pain that we're trying to advance, we are very, very dedicated to. Next slide. It's realistic, it's scalable. We have good evidence for it. So again, I'm hoping that we can push for that. And we're looking for partners everywhere that we can. Next slide. This is really the end. So again, I want to go back to this. If you don't know where you're going, you may not get there. We need to be really clear as a field that we need to know that we've got to address education. It's forgotten. It truly is the elephant in the room that nobody's talking about. We're spending billions of dollars on trying to find a better opioid or an opioid, a different molecule. And honestly, I think that we would make much more gains if we at least invested some minority of those funds in changing the knowledge base for our clinicians. So next slide. So with that, I thank you. I thank the U.S. Pain Foundation for putting this on and giving me this opportunity. So thank you.
Thank you, Dr. Fishman. Really excellent presentation. And thanks for your incredible dogged attention to getting doctors better trained in this country. I'm sure we're getting a bunch of questions about your work, but I really appreciate it. And thanks for being here. So next, I'd like to introduce Dr. Scott Lawrence from CMS, who is joining us today, and we're very lucky to have him. Dr. Scott Lawrence is the Deputy Director, the Division of Practitioner Services within the Hospital Ambulatory Care Group at the Center for Medicare, within the Centers for Medicare and Medicaid. He is the government technical lead for the physician fee schedule telehealth evaluation, something quite important to all of us. And he has been the Deputy Director of the Division of Payment Methods and Strategies in the PCI section of CMS. He's also been acting Deputy Director of the Division of Data and Informatics, leading the Healthcare Fraud Partnership and the Data Sharing and Partner Group at CMS. He's also a physician who sees patients in private practice. So please welcome, join me in welcoming Dr. Scott Lawrence.
There we go. Thank you very much. I appreciate the invitation, and fascinating to listen to the presentations by Drs. Fishman and Nagel, so thank you very much for that. It's interesting, as I was preparing for this talk, which was originally to be presented by Dr. Sherry Ling, the Deputy Chief Medical Officer for the Centers for Clinical Standards and Quality at CMS, and was unable to join you, so I do apologize on her behalf. But I was thinking about pain, something I know a great deal about as well, and I'm just going to relay a small story about back in the day when people used to go to places where stores were all in one building called malls, and I was seeing a group of people, which there were many people all together in those days, and there was a small family, and there was a young girl speaking to her mother pretty much constantly, and the mother said to her, "Can you just keep some thoughts to yourself just for a short period of time so I can think?" And it made me think of pain and how pain works. pain for many people is a constant communication system that just blocks their ability to think about other things. And I wanted to relay that we understand that at CMS. And to be clear, CMS is part of the Department of Health and Human Services, and we're the Centers for Medicare and Medicaid Services, which we abbreviated to CMS. We do like acronyms. And so Dr. Ling is part of a different center than I am. I'm in the Center for Medicare, where we write the payment policy for how things get paid. And we'll talk about some exciting new things we're doing with respect to pain. I'm going to share my screen here so we can start the slides. So can everybody see the slides there? I will assume
Yes,
that you can.
yes, they're visible.
Perfect. Thank you very much. So I'm going to go over some of the discussion about what we've been doing at CMS with respect to pain, and we're really going to deal today with mostly what's going on in the behavioral health area, an area that we have a lot of focus, and I'll go through these slides fairly quickly. There's lots of information to cover. I want to be sure we have time for questions in the end. But ultimately, we have a roadmap for a strategy to fight the opioid crisis, which, as everyone knows, is a real problem in this country. We have the SUPPORT Act, the Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients in communities Act, which helped us give some authority to take some of the action that we took. We also are looking at some other strategies. There's the HHS, the Department of Health and Human Services Behavioral Health Coordinating Council, and BHCC, we like our acronyms. There's a coordinating body across the department, and CMS, which is part of HHS, is represented in all 5 of the current BHCC subcommittees: the Overdose Prevention Committee, the Suicide Prevention and Crisis Care Committee, Behavioral and Physical Health Integration Committee, the Child and Youth and Behavioral Health Committee, and Performance Measures and Data Evaluation Committee. We also have a number of strategic pillars. So we talk about advancing equity, and this is very important to us and our administration. We're trying to be sure that we can address disparities that underlie the health system for people to get access to care. We are expanding access through both the Affordable Care Act, but also through other initiatives that we have within CMS. We're engaging partners both within the agency and interested parties outside of the agency. We're working to drive innovation to tackle some of the health system's challenges as we continue to change. And as I was sort of alluding to before, the pandemic and the public health emergency has forced a lot of change. We heard Dr. Fishman discuss how they were able to use telehealth, which was something that was really pushed forward in my area. As was described before, I was one of the government leads for telehealth and continue to do a lot of work in telehealth and how it works, just to try and enable people to gain access to care in an ever-changing environment. We protect programs for sustainability for future generations. It's very important to us that everything we do is sustainable, and we work to foster excellence in a positive and inclusive workplace so that our workers can also do the best they can to try and help people out in the country. CMS has cross-cutting initiatives as well. So we have our national quality strategy, which works on advancing health equity, embracing the digital age, strengthening resiliency. We foster engagement with stakeholders and other interested parties. We try and incentivize scientific innovation. We promote safety and to try and achieve a zero harm and increase alignment to promote seamless and coordinated healthcare. And we do this also through coordinating between 5 priorities that I'll talk about in a little more detail: expanding the collection, reporting, analysis of standardized data, access causes disparity, or assess the causes of disparity within CMS programs, building capacity for healthcare organizations, advancing language access, health literacy, and provision of culturally tailored services and increasing all forms of accessibility to healthcare services and coverage. But behavioral health itself is a much larger picture. And within behavioral health, we have to deal with mental health, substance abuse, and pain, both acute and chronic, and then also the subcategory, acute on chronic, as just small parts of our overall behavioral health strategy. And this, as you heard Dr. Fishman talk about, moving things into a more national setting from a statewide setting. This is exactly what we do at CMS. In the Medicare side is we work on a national level. There's lots of variation that goes on in the country in different areas, and we have to be sensitive to all of those differences and try and capture and create systems that will touch the people in the correct way. For our behavioral health strategy, our mission is to make high quality, affordable, effective, equitable, and data-informed behavioral health, mental health, substance use disorders, and pain care services available to our CMS consumers. And our vision is that consumers receive person-centered behavioral health, mental health, substance use disorder, and pain care services that successfully address their needs and foster healthy lives characterized by independence, self-determination, hope, dignity, and meaning. For our strategy goals, which we talked about before, we're going to go into them in detail. So goal number one, strength, equity, and quality in behavioral health. In these next few slides, we will have on the one side our objectives and some of the activities that we're doing to try and achieve those objectives. We're actually very, very active in these areas and working very hard to try and make healthcare available and appropriate for all of our beneficiaries. So we're trying to reduce disparities, which is, when you're looking at a national scale, isn't always as easy as it may sound. We're incorporating health equity into new care and payment models to optimize whole person care for beneficiaries with and at risk of behavioral health conditions. We provide effective outreach and education on CMS behavioral health services. We're improving quality measurement in behavioral health and pain management across our CMS programs and consider quality and equity implications across all the objectives of CMS behavioral health strategy to ensure that both underpin the CMS approach and also improve substance use disorders, pain management, behavioral health, and data and measurement. Through these activities, we have our OMH, our Office of Mental Health, Health Equity Accelerator. We have behavioral health quality measures inventory. We have the Medicaid and the Children's Health Quality Improvement. We have the Tmsys data analysis, which is the data project that we have to try and capture the experience of patients in the Medicaid and the CHIP systems, which is a very complicated process because similar to Dr. Fishman said, when you have seen the system of one state, you've seen the system of one state. Of course, there's 50 plus some regions and some other demos and models. We'll go into them a little more further. The Medicare physician fee schedule updates, which is the area that I work on a daily basis, and we're working heavily on that now, and we'll have more on that in a minute. Goal number two is to improve access to substance use disorders, prevention, treatment, and recovery services. So we're trying to improve the care experience. We're trying to identify and address barriers. An interesting thing that happened as we were looking at telehealth, for example, is not only do we get to see the people that were being touched and were being able to access telehealth, we were trying to tease out of the information who was not able to get it. There are people that just don't have the ability to get into technology, and we need to try and come up with ways to get care to them. And it's not just technology, it's language, it's a number of different things that can create barriers, and we need to be sensitive to all of those things. We're trying to strengthen treatment and recovery services and expand workforce capacity in a number of different ways. And you can see how the bullets on this side are numerous, and the text got a bit smaller. We have the data that we're looking at. We're looking at different sort of prescriber support strategies, different models and demonstrations. All these things occur. And then, of course, we have the Medicare physician fee schedule updates to telehealth and audio only communication, which again is my area. Areas in the Office of Mental Health, Medicaid and CHIP, and then action plans with respect to the Support Act. So many initiatives going on there. Our goal number 3 is to improve the care and experience for individuals, expand access to evidence-based treatments, increase coordination, expand workforce capacity again. And you can see we have a number of initiatives working toward that. And I'm just trying to be sensitive to the time so we have the ability to have some questions. Goal number 4, improve access to quality and mental health care. I don't want to make small of these things. These are all important goals of ours, and we work very hard, as you can see from the list of our activities, that we're doing lots of different things to try and make these goals a reality. Goal number 5 is to utilize data for effective actions and impact. CMS has a tremendous amount of data, and we try and leverage that information to make and inform our decisions for future activities. Being a federal agency, we can't do things quickly usually, or as quickly as people would like, because of the necessity of notice and comment rulemaking and things like that. Like the work I'm doing now is currently for the 2023 calendar year, and we're already making plans for our 2024 calendar year. So, and we'll get to that in a minute, but these are all very important goals of ours. I wanted you to see that you can get some information about what CMS is doing. And even if you're not a Medicare or Medicaid beneficiary, I can say that much of what we do gets borrowed or looked at or used in some way by the other health insurance payers or carriers, things like that. I encourage you to go to www.cms.gov, and then in the search, go to behavioral health strategies and or strategy, and you'll see a host of information that will tell you about the initiatives that we're doing and all the resources that are available, or many of the resources that are available. I want to share this next slide. This is a beautiful graphic. And I would like to say that my area made these graphics, but it was done by Dr. Ling's area. So I do thank her for making me look good. But this is based on some interviews that we did with different beneficiaries and patients and doctors about what it's like to be in chronic pain. And this is a beautiful graphic. You can see in the bottom, you have people with pain who have the weight of that pain on them. Their family members and caregivers that are lost, at a loss of what to do, people looking for support. And then you have these cliffs that show sort of the obstacles that they have to go through to try and get some help. And if they can actually get to the top level, so if you look onto the top left side where you have the patient actually with the provider practitioner at this point, you have all different things going on. As Dr. Nagle said and Dr. Fishman said, you know, can they communicate well? What's going on between them? Is the practitioner able to openly even understand and ask the right questions, have the tools? Sometimes they're afraid that they're going to do the wrong thing, especially when you come to different types of medication management and things like that. And then when you get to that system, can you access complementary or integrative care? I don't favor the term complementary care. It sounds like doctors saying, hey, you did a nice job on that case. Thank you very much. But ultimately, you can see by the person with all that pain weighing them down, walking this sort of precarious tightrope, that they have the work and day-to-day tasks, they have family, friends, and caregiver issues, financial burden, quality of life issues, mental health issues. They're juggling that while they're trying to manage all these things. Not very simple, but we have those nice purple support systems of provider collaboration, appropriate medication, person-centered decision-making, appropriate implementation of prescribing guidelines, interventional approaches, therapies, behavioral health services, and providing care for co-occurring substance use and mental disorders. This is what we're trying to achieve. You can see these things are there. I will offer that in the physician fee schedule this year, we have proposed to create a new set of codes to help doctors incentivize the use of time to try and manage pain. So the code is based on time spent with the patient. It's a base code and an add-on code. They're all time-based. So they're not just quickly writing a prescription and moving on. They spend time with the patient to ask questions, to understand the cause of pain, because pain, as we all know, is a system of communication. It's not a disease. So it's something that needs to be investigated to figure out why the pain is there, and then working toward managing those things whenever possible. Of course, there's many different types of pain, and there's maybe as many types of pain as there are patients with pain, but it's a crisis that our country is in, and Medicare takes this crisis very seriously. So with that, I will leave this graphic up. I have a thank you graphic, but I think this is a more interesting graphic. And I will pause there and see if we can move to questions.
Thank you very much, Dr. Lawrence. I really appreciate your presentation and for you joining us today. And I'm sure we're going to have some questions for you. So thank you. Lots of questions are coming in, and I have a few that are directed questions. So for Dr. Fishman, are there patients involved in your trainings and in their creation? And is the overall satisfaction with the insurance companies or with the patients?
Excellent question. We do have patient groups that help us look at the curriculum, and we have community supporters for this. But honestly, we probably don't have enough. And if you could think of the complexity of trying to create a education program for physicians, there's really no support to do it in the first place, and then to try to bring in the patient voice, it's just an unsupported mandate. So I think it's a great question, and I'd have to tell you that even though we do have patient input, we don't have enough.
Well, you can always come to US Pain Foundation if you want to find more patients that want to participate. So
maybe we'll collaborate.
we welcome you to do that. Now for Dr. Nagel, I had a particular question, and it is, Dr. Nagel, you attended a comprehensive chronic pain support group training from the US Pain Foundation. Did you find attending the training helped you better understand and treat patients? Do you believe that similar training should be an integral part of training of future physicians? And thank you for being the only doctor to have attended one of our 10 sessions.
Yeah, I actually know who asked that question. So, you know, I grew up in a house of pain. Anybody that reads the first chapter of my book, that's what it's all about. I mean, I learned more from that setting than I ever did in med school about pain. And I also learned when I was at Rochester that, you know, we learn more from our patients than we do from other doctors, that if you wish to listen. So to me, the opportunity to have it was a 3-day training, right? If I remember right, or was it 2? So, I mean, to have 3 days of concentrated interaction with patients to live in their world for 3 days, you know, with people suffering from all different kinds of pain. I mean, I don't think that is the best education you can ever have as a doctor. And should it be part? I mean, you know, what I've done is I've told other people about it. I said, this is really, if you really want to understand what you're doing, this is the best place to go. So my concern is that, you know, every time I give a symposium or presentation, I insist that a patient be part of that. And I'm amazed how much negative feedback I get from doctors. So there's a little bit of a barrier there, but you know, if you just kind of beat the horse, and eventually maybe it'll get moving and somebody will come. But no, I think it was awesome. It was great. It was the best thing I've done in 40 years of pain management.
Thank you. It's amazing that you took it. Really, we're really appreciative. Let's see. We got an interesting question for Dr. Lawrence, which is, can we hear more specifics on the new CMS codes for pain management, an example of how it would work for patients? Just flashed out of my screen here for a second.
Certainly. No, thank you. That's a great question. So for patients with chronic pain, they can see their physician, and there are certain criteria that the physician would have to follow for the code to be payable based on the way it's proposed. It's not finalized yet, so I can't say too much. But what I will say is how we envision it from our proposal is that your doctor will visit with you and take time with you. The base code is a 30-minute code, so it isn't something they can just do quickly. It's based on time, and then they have an add-on code that would be 15-minute increments beyond that they can do as many as they need to in a given month for the add-on code for that same date of service. So it enables them to coordinate care. It's designed to be a pain management code. So they would coordinate care, and they would look at maybe working with other professionals to help you manage your pain. And it's about management and listening to the patient and trying to understand the causes of pain. It's not just a way to get people through the door, because for chronic pain, they're usually multifactorial, and the best way to approach them is with good information. So we are trying to incentivize the access of that information, and I hope that answers your question.
Thank you, Dr. Lawrence. And as a follow-up to that, I would say that we in the pain world were really happy to see that you've sort of, as part of the code, outlined all the steps that doctors ought to take with pain patients. How will you be sure that they are in fact doing those steps, including a thorough assessment and developing the treatment plan and then revising the plan? How will they show to you that they're doing those steps?
So I was hoping you'd ask this question, and thank you very much. So there's a number of ways that we do this. I just want to be clear. So the way this process works when we create a new code is we propose it through rulemaking, which means we publish it to the general public, and then comments come in. We received more than 12,000 comments on pain management as I checked the numbers after preparing for this. Many of which came from certain organizations, so they were organized, and we also had just individuals writing in. We look at every comment that we get. So for the physician fee schedule, we will get somewhere between 30 and 45,000 comments on all the different proposals that we make, and we look at them all. It's important to us to see what people think. We work very hard to try and get it right. And not have to redo it. But sometimes we have to do things incrementally. So in this case, as far as pain management is concerned, we will watch the utilization of the codes. As they come in, we can gain that information. If we need to, we can reach out to the physicians and see what they're doing. We'd like to get feedback from any interested party. So it includes folks on this webinar right now to write in on your experience. And currently, we just have it set up so it's for people who can do medication management. And we're looking for feedback about other types of practitioners who manage pain, and what interest there would be in having those types of people available to build these codes and manage pain. We do know that there are a lot of folks out there who manage pain in ways that don't necessarily involve medication management, at least primarily. And we're looking to get feedback from the public to see what their interest is in that. So please write to us. We're interested to hear what people think. And you can check the Federal Register, which I know is a very exciting reading, because we write in there. Our rule is something like 1,500 pages, but skip to the pain management part if you're just interested in that. And please feel free to comment on your experience and things that might be helpful.
That's fantastic. It's really great to know that you do look at all those comments. I tell patients all the time to write in, and I think they think, well, who am I writing to? No one's ever going to look at them, but it's nice to know that you really do. And are those comments only looked at during that, are they just during the comment period, or can patients continue to write in any particular way to you?
Sure. So we look at comments all year long, but during the comment period, which is over now for this particular rule, that's when it's particularly important, because that's when we will focus all our energy on that. Any comments that are straggling in now, we get to, but it's not our priority. Our priority is getting this through, because by statutory law, by congressionally passed law, we have to get the final rule out the door by November 1st. And there's lots of briefings and clearances and things that we have to get. It's a very, very, Winston Churchill said, democracy is the worst form of government in the world, except for all the others. So it's a necessarily complicated process, and we're going through all that now. But we are always interested to hear from interested parties and the public on their experiences, and we learn. We're very interested to know what people are experiencing, because we do the best we can. We have a team of medical officers and clinicians and lawyers and things on our side who have their own experiences, but we're always looking to get more feedback.
Thank you, Dr. Lawrence. And I have one last question. I see we're a minute or two over, but I'll ask this last question of Dr. Fishman, which is lack of a specific diagnosis is often a barrier to care. Is there anything being done to educate providers that pain is pain, whether we understand where it exactly is coming from or not?
Well, again, it's part of that competency goal of, you need to understand pain. And part of that understanding is that you can't prove that anyone does or doesn't have pain. It's really that starting point that science is not able to prove that. So it's essentially addressing the humility that we have to have when we address someone in pain. This idea that we know they do have pain and they must take this, or they don't have pain and they don't deserve that, is silliness. And again, speaks to, the ignorance of being uneducated. So it's a very profound question that's asked. And I think that it's the first part of addressing that first competency, what is pain?
Thanks. I think part of it also is understanding pain can be its own disease, which still physicians don't totally understand that.
Absolutely.
Really easy paradigm shift. But anyway, thank you so much to our really distinguished panel, and thanks for taking the time to answer all our questions. We've gotten so many that we will continue to answer them, and ones we can't, perhaps we can send to our speakers, but thank you so much. I really appreciate you being here today. Take care.
Thanks.
Thanks to our audience also, everyone. If we're gonna have the next slide up, just want to reiterate that we had the last slide possible, maybe not. In any case, we have a recording. It is available on our website. It was just giving the exact location, but go to our website. I think it's uspainfoundation.org/webinars, and you will find it. Thank you, everyone, for participating.
Thanks.
Bye-bye.
Thank you.